Right then, welcome to GP Study Bits. Today, we're tackling a topic that, trust me, you will see time and time again in your GP surgery. And, it's pretty much guaranteed to pop up in your AKT exam, childhood constipation. Getting this right from the very beginning can make such a huge difference to a child and their family. And look, this isn't some trivial problem. This quote from a pediatric trainee really brings home the real-world impact. We are talking about a condition that causes a huge amount of distress, and our job in primary care is to manage it really effectively to stop these kinds of scenarios from happening. So, we're going to approach this just like a real consultation. We'll kick off with the presentation, then move on to the really important red flags and investigations, then we'll build a solid management plan, and we'll finish up with some high-yield facts specifically for your AKT revision. Let's get started. Okay, first things first. A child's been brought into your surgery. The parents are worried about their bowels. Now remember, a focused history is your most powerful tool here. It's all in the questions you ask. So what are we actually talking about? Well, the official definition is fewer than 3 complete stools a week. But for parents, it's often more about a change from their child's normal pattern. And it's incredibly common. We're talking about 1 in 10 kids with these classic trigger points like weaning, starting potty training, or going off to school. Now, the Bristol stool chart. This thing is an absolute godsend in clinic. Why? Well, it cuts through all those vague descriptions. Parents might say diarrhea when what they really mean is overflow, or hard stools, which could mean anything. Just show them this chart. It gives you a common language and, crucially, a clear treatment target. And remember, during maintenance, we are aiming for a consistent type 4. These are the absolute key points you need to build your clinical picture. You've got to actively ask about them. Ask about rabbit droppings. And crucially, ask about overflow soiling. Parents so often mistake this for diarrhea and might have even stopped laxatives because of it. And you need to look for descriptions of retentive posturing. That classic straight-legged, back-arching stance. That's a massive clue that a child is fighting the urge to go because they've learned to associate it with pain. Okay, now for what is arguably the most important part of the assessment, safety. Before you even think about diagnosing simple idiopathic constipation, you absolutely must actively exclude the red flags. Your tone with the family can be reassuring, of course, but your internal thought process here has to be sharp and rigorous. This table is non-negotiable. If any of these features are present, you do not start treatment in primary care. Your job is to refer urgently. Pay really close attention to the timing. Onset from birth, or a delay in passing meconium for more than 48 hours is a huge red flag for things like Hirschsprung's disease. And on your examination, look for faltering growth, a really distended abdomen, and always check the lumbosacral spine. So, you've taken a really thorough history, you've done your examination, and there are no red flags. So what's next? Well, the good news is, for straightforward idiopathic constipation, less is definitely more. Let me just say that again, because it's a really important point for your confidence as a registrar. A positive diagnosis of idiopathic constipation can be made on the history and the examination alone. You do not need a battery of tests to confirm it. And this slide spells out exactly what we should avoid. A digital rectal examination is not a primary care procedure for this. That's for a specialist. Abdominal x-rays, they don't change your management, and they just expose the child to unnecessary radiation. And blood tests are only for very specific situations, like faltering growth, and are usually initiated by a pediatrician anyway. Right, so you've made a confident diagnosis. Now it's time for the management plan. And this is all about education, explanation, and a really structured approach to the medication. This diagram here is probably your single most important communication tool. You need to explain to parents that the bowel is basically blocked with old, hard stool. The soiling they're seeing isn't diarrhea. It's new liquid stool that's leaking around that blockage. And this perfectly explains why starting laxatives can actually make the soiling worse before it gets better. Managing that expectation is absolutely key to getting them to stick with the treatment. So, the crucial point is to follow these 4 stages every time. First, build that rapport. Acknowledge how stressful this is. Second, explain the mechanism using that diagram. Third, if there's a backlog, if they're impacted, you need to clear it out decisively. We call this disimpaction. And finally, you must have a long-term maintenance plan to let that stretched bowel recover and to stop it all from happening again.
I really can't stress this enough. Before they even walk out of your room with the prescription, you have to warn the family that for the first few days, things might actually seem worse. There could be more soiling, more tummy pain. Reassure them this is a sign the medicine is working to clear that blockage, and tell them to use simple paracetamol for any discomfort.
Here we have a pretty typical escalating regimen using pediatric macrogol sachets. The principle is simple. You just keep increasing the dose until you get the result you want.
And what is that result?
Well, success is defined as the child passing watery type 7 stools. That's your signal that the backlog is cleared out. The second that disimpaction is done, you switch straight to maintenance. The goal now is a daily type 4 stool. A good rule of thumb for the starting dose is about half of whatever the final dose was that was needed for disimpaction. And listen, the most common reason for treatment failure is stopping too soon. You got to advise parents to continue the treatment for several months and then wean it down ever so slowly. Your job isn't done when the family leaves the room. Proper follow-up and really clear safety netting are essential parts of good medical practice. You've got to close that loop. Here are your key time frames. You need to review a child on a disimpaction regimen within a week. For maintenance, regular reviews are still needed to check everything is on track. And you need to know your referral thresholds. For an infant under 1, refer if things aren't getting better after 4 weeks. For a child over 1, that threshold is 3 months of failed optimal treatment. And finally, always signpost families to the ERIC website. It has some absolutely fantastic resources for them.
Okay, let's switch gears for a moment. For the exam, you need to have the key facts right at your fingertips. So let's quickly cover some really high-yield points and a few of those common distractors they love to throw in. This is a classic AKT scenario designed to trip you up. Infant dyschezia versus constipation. The key differentiator, the thing that tells you the answer, is the consistency of the stool. In dyschezia, the infant strains, they go red, they cry dramatically, but then they pass a completely soft stool. It's just a benign, self-limiting coordination issue. In constipation, all that straining is associated with passing a hard stool. It's a simple distinction, but a crucial one.
So, for your exam, burn these 4 points into your memory. First, an exclusively breastfed baby who is otherwise well can go a week, maybe more, without a poo. This is totally normal. Second, macrogols are first line for everything, both disimpaction and maintenance. Third, while diet's important, it is never the first line treatment on its own. And finally, always, always, always exclude the red flags first. And to finish up, here is a typical single best answer question. We've got a 6-month-old, lots of straining and crying, but then passes soft stools. The baby is otherwise well. Take a moment, think about the answer, and apply what we've just discussed. That's all for this study bit. Thanks for listening.